Okay, thank you. It's nice to meet everyone. We do have quite a good mix, I think, of people who are practicing advocacy, those who are not, those who work through partners on advocacy. So I think we shall have quite a good discussion. And so this roundtable was designed for people like us, a mix of people, both practitioners and advocates, to exchange our experiences and lessons learned on how we have had to adapt or pivot our programs given the COVID-19 pandemic, and how we can continue to advocate for family planning needs given the pandemic. And to take it away, I think we're going to start with I just wonder if at all we have been doing any advocacy during this time. Is it even possible? Have you been doing any advocacy, those who used to do advocacy before COVID? And has it been effective? What has worked? What hasn't worked? I think we can start there, and you can just raise your hand or unmute your mic. We'll take it away.
Great, Moses. I think your hand was up first.
Okay, thank you so much. In the context of COVID at the start of the lockdown, this is experience from Uganda. At the start of the lockdown, you realize that there was almost a total shutdown in the delivery of essential health services, including the broader SRHR, where family planning is. And later, the challenge was that in many of the subnational areas, especially in the districts and the health facility level, people never thought that family planning was an essential service. So whatever resources were available, apart from dedicating them to the COVID response, they were mainly geared towards provision of maternal health service, especially the maternal delivery services. But no one thought that family planning was key at the decentralized level. And the political wing that was mainly in the leadership, the heads of the task forces at the decentralized level, even when health workers engaged them to ensure that they allocate resources towards provision of family planning services, whether at the health facility level or whether through the community delivery channels. They could not give approvals for that. And then the other challenge was that the implementing partners were all, because of the travel restrictions, could not move out for the districts and the communities to support the delivery of family planning services. And so the first advocacy we did at the national level was to ensure that we incorporate family planning within guidelines, within the continuity of essential health services. So we had to draft family planning guidelines and get incorporated within the essential health services guidelines. And we ensured those get rolled out at the decentralized level. And then the second thing was to engage the ministry and the National COVID Task Force to ensure that there is the transport waiver, there are waivers for implementing partners, especially those providing reproductive health services, to move out to ensure that there is service continuity, because they couldn't continue providing that because they were blocked from moving to the facilities. And then the third area of advocacy that we did was to work with the implementing partners to ensure that at the COVID task forces at the decentralized level, they constitute a subcommittee on the continuity of essential health services where family planning is included. So that was a key element as well. And of course, my last contribution is on the advocacy to ensure that family planning commodities continue moving out. What happened is that the national warehouses that are in charge of storage and the last mile distribution of commodities prioritized the COVID commodities and supplies, especially the PPEs. So they hardly prioritized the delivery of SRHR commodities because the focus was on the COVID response PPE items. So we had to engage again the government and the warehouses to ensure that they also rationalize space to deliver the reproductive health commodities as well during the pandemic. So that helped us to maintain the pipeline for FP commodities during the pandemic period. So over to you.
Yes, thank you so much, Moses, for that submission. A good way to start us off with what you did in Uganda to, you did advocacy adaptively to ensure family planning remained essential. Maybe what you didn't get to is, did it deliver the results you intended to achieve?
Yeah, thank you so much. We had a dip in the first 2 months of the local, especially the first 1 month. That's when we had a dip in the FP service provision. But then after that, by the 3rd to 4th month, we had actually gone, the uptake had gone to the pre-COVID situation. So we had to adapt the approaches, but also we had to ensure that there is routine monitoring, and we had to ensure that the data from the service delivery points comes to the national level for us to be able to track and monitor the progress, and all the districts that had challenges in terms of implementation and submitting the data, then they would be supported by the national task force. So apart from the dip we had in the first 2 to 3 months, subsequently we were able to continue providing services, and the uptake was almost to a pre-COVID situation.
Okay, thank you so much. And of course, Moses gave us a very good intro into this discussion. I would like to pick on someone from another location.
Frederick, sorry, quick question. Can you see people's hands who are up? I know when we tried it earlier,
no,
you couldn't. Okay. All right. So Sam's hand went up, and also Adenike. Okay. So Sam was next, I think.
Okay, Sam, please. So you can tell us some how either advocacy continued in your context, or how you pivoted services. Please, it's your floor.
All right, just as Moses had mentioned, once COVID hit the countries, most of African countries, including Kenya, where I stay, witnessed lockdowns. And if you are living in the capital, such as Nairobi, it was even tougher because you couldn't enter or exit Nairobi. Because being the capital, the center of communication, this was the hardest hit area in the very beginning in the country. And therefore, as advocates, advanced family planning, which is implemented by JPIGO in Kenya, we started wondering, how shall we reach out decision makers to tell them, hey, we need some attention towards family planning if we cannot meet in person. And even these decision makers were also learning to use technology. Most of the government offices and many people, generally, this has also been a technology revolution in terms of using it to make decisions. So what we did, we had several approaches. One approach was media advocacy. And basically, we had trained journalists, even before the COVID-19, on how to do family planning reporting. And since the Kenya government had categorized journalists as essential services, basically the media as essential services, or essential workers, so to say, they could go everywhere. And therefore, these journalists who had oriented in family planning reporting, and they had even a community of practice, started bringing up human stories, even in the grassroots, on how people who need other services other than COVID are being affected, even with fear of going to health facilities. And that just will increase even deaths from non-COVID ailments. and other services that might not be diseases, but family planning and other needs that people need. And therefore, when these reports started coming up in the media, it started raising attention of decision makers around essential health services, that they need to do something. We also used another approach to bring the various stakeholders in the reproductive and family planning community to have a dialogue around this, and met the decision makers through virtual platforms. What was the outcome? The very immediate outcome was the Council of Governors in Kenya. This is a body that brings all governors from all the subnational levels and who are responsible for family planning and even health in general, issued out a memo to all their jurisdictions that they need to continue essential health services, including family planning. So that was great. And we had also the Ministry of Health now even issuing guidelines on continuity of essential health services. At the end of it all, as you might have noted in the PMA presentation, even during the panel today, and even if we look at our service statistics, we noticed that for that period where essential health services were not being provided, the first and second month or so, but more so March and April, things went down. There was a dip. But after now, this circular started going there, there's more attention of government now saying, hey, please, you can still get the other services. We saw that the data for family planning actually started accelerating and going even much higher up than even the previous period before we had COVID. Over.
Yeah, that's quite interesting, Sam, and especially the use of the media as kind of the mediation between the advocates and the authorities, and there was a clear outcome. I think we had Adenike with your hand up. I'd like you to share again what the pivots were in your context. Yeah.
Okay, thank you. At the onset of the lockdown, when the pandemic broke out, it brought out to the fore the need for family planning services, because there were escalated issues around domestic violence. And if you investigate further, husbands and wives that go about their businesses on normal days are forced, to stay together during this period. So there were serious issues around accessing family planning services, and most especially because of the restriction of movements. What we did as a program was to, because with the feedback we were getting from the communities, through the state-led accountability mechanisms for RMSCH, is a platform where we have civil society organizations, development partners, community leaders, traditional rulers, and government representatives coming together to discuss issues around RMSCH and getting evidence within the system to advocate to policy stakeholders to improve service delivery. So the feedback we were getting from the field were all these issues around, most especially even women that are even living close to health facilities, were not going there for the fear of contracting the COVID-19 infection. So it was a very, very difficult period for clients and patients accessing services at the health facilities. Also, because of restrictions of movements, getting commodities to facilities also became an issue. And, with all those evidences and facts, we're able to come up with statistics that were used to create advocacy messages. And what our program did as Ifoye Mamaye, we trained the SLAM members on how to use the social media, for digital advocacy, which it's just like one of the speakers before mentioned, you know, we have entered an era that has revolutionized the use of the media. So we saw that as a very important tool at that moment to advocate and reach out to the policy stakeholders to take necessary actions that will make the FP services available and accessible to the women and girls who need them at that point in time. So we'll train them on how to create messages for social media, you know, with the use of the Twitter, going into the Facebook. And we made sure that, you know, we gathered the social media handles of the critical stakeholders that we were supposed to reach out to. And with that, we launched out a campaign, and we were able to also synergize with other partners that also work within the reproductive health space. And it became a very loud voice to, you know, for them to respond to FP issues in the states where we work at that time.
So Adenike, a quick question for you. So you were training girls and women or young, you know, the general public on social media so that they would then advocate to politicians and people at the ministries and things like that? No,
we were training the advocates.
Okay, so people already identified.
Yeah, people already identified.
Okay.
The slums are made up of different groups, like we have the advocacy subcommittee group within the state-led accountability mechanism for RMNCH. We have the evidence subcommittee. Those are the people that go out to gather the data, put the evidence together, you know, review and produce them into formats that could easily be used by the advocates to engage the policy stakeholders. And then the media. We also have the knowledge management subcommittee within the mechanism too, and they are mostly media people, you know, who are able to, you know, take the advocacy messages to either use the social media, the traditional media, or the prints, you know, to reach out with messages to the populace.
Thank you.
Interesting, Adenike, and very, you know, excellent use of social media. I can see, especially where you even picked out the handles of key influencers, the media, was it the social media handles, and you worked with them. I think that was quite interesting. Penelope, I cannot see any other hand up.
Yes, that's it on that question.
Yes, I think I want to move us to another discussion about, so of course to get the advocacy happens normally, it's directed towards leadership, either in programs or in government. And so it would be interesting to understand how within the context of COVID-19, we worked together with leaderships and in organizations, in government to get things moving, because of course their attention, their focus was, you know, at averting this big emergency. And so it would be interesting to understand how this played out in the various contexts regarding how, you know, you adapted, how their leadership adapted to your advocacy efforts, and yeah. So if anyone wants to pick on this again, I still see Adenike's hand up, but I would like to invite anyone who has any other experience as well to get ready after Adenike speaks. Oh, I see. Go ahead, please.
Right, can I go on? Okay.
Yes.
I will use the states where I work, Lagos State, as a case study, as an example, rather. By the time the messages, kept flooding the social media space, and we also had people going on radio, speaking about all these issues around reproductive health. One thing that we also discovered as a mechanism was that at that point, because of the major shift of funds to the COVID-19 treatment and prevention, there were no releases for program funds for other areas of health service delivery. And when we did the analysis, we discovered that as at the month of March, April, May, June, 2020, there were no releases for RMNCH programs. We also use that as an evidence because while we were producing messages for the social media, we also produce small videos with messages, with graphics, to put face to the advocacy messages and actually get attention of the key influencers. We discovered that the government, decided to respond to releasing funds for RMNCH programs. And one thing we discovered was that any of the other health programs that is not COVID-19 related were not getting funds released for them. So we had to get back to the Ministry of Health to look at how COVID-19 prevention protocols could be introduced to some of the essential services that has to do with reproductive health. And when they had to go back, rewrite their proposals and all that, they were able to get funds released for those programs, especially when we're talking about, providing PPEs for health workers, those that will be at the labor ward, those that will be, delivering family planning services. If they are not protected, definitely clients coming to the facility will not feel protected, from getting the infection. So we saw that shift in government's response to releasing funds for MNCA services because they had to reprogram all their proposals to incorporate COVID-19 prevention programs into their RMNCH services delivery. And by the time we were getting to August, they had about 81.4% release of their funds, from zero at the end of June to that whooping increase within 2 months interval. So it was a very big shift in responding to plights of funding for RMNCH programs.
Thanks, Denike. That's really significant. 81% shift, and they had to reprogram the funding to make it available for family planning. I think that was a big outcome. We had Lamine. You have your hand up, please.
Thank you, Frederick. Just I would like to share the experience of what we are doing in Burkina Faso, particularly with the Ministry of Health, under the program called WISH, which is Women Integrated Sexual Reproductive Health, funded by the UK government, FCDO. So in Burkina Faso, when we work there, the government allocated about 1,300,000,000 local currency CFA for the purchase of family planning commodities for the fiscal year of 2020. And then just before the arrival of COVID-19 crisis in the country, the Ministry of Health developed national operation guidelines on how to maintain essential maternal and child health services, including family planning during COVID-19. But we discovered that the guidelines developed by the Ministry of Health was not developed based on any evidence. So therefore, what we did, we worked with the Family Planning Technical Working Groups, which is a coalition of civil society organizations working on issue about family planning and sexual reproductive health. And then, we support them to work with the Ministry of Health to carry out rapid assessments about the capacities of health facilities in Burkina Faso to maintain essential sexual reproductive health and family planning service during COVID-19. So based on after that exercise, that coalition of civil society organization with the leadership of the Ministry of Health, they work together to organize a national dissemination workshop which aimed to validate the conclusions and the findings and the results of that rapid assessment. And then the next steps, we as options to the WISH program, we help both the civil society organization, the Ministry of Health, to use the findings to develop a policy brief. And the policy brief was used to advocate among parliament members to make sure that the family planning budget for 2020, which was about 1,200,000,000 CFA, will be protected during a COVID-19 crisis, because we found that there is a time the government of Burkina Faso was trying to find out the best way on how to mobilize additional funding to support the implementation of the COVID-19 response. So they tried to cut some budget from the malaria program, from the HIV program, but finally, and based on the fact that the policy brief was used by the civil society organization to advocate for the protection of family planning budget. And finally, that was really protected. And the civil society organization will work very closely with the network of parliament members on health within the National Assembly. And there was a very actors to advocate within the National Assembly how to make sure that that FP 2020 budget will not be touched, but will be protected during the COVID-19. And then we work again with that civil society organization group dealing with issues about family planning and SR to hold a national media briefing with the Association of Media Professionals in Burkina Faso on issue about the need to protect family planning public investments during COVID-19. And as a result of the media briefing, some media association were able to produce and publish some articles about the need to protect family planning public investment during COVID-19 crisis. This is just I would like to share for the case of Burkina Faso.
Yeah, quite interesting, especially the fact that you usher us into one of the things we actually wanted to discuss next, which was how would we advocate for funding for FP programs, both at domestic level and with donor governments, including official development assistance in this context. And you got us started with how you managed to lobby, I think, through the National Assembly, but also using the media again. So it looks like media is running through most of the efforts. But if you have any additional points about maybe, because you talked about the domestic level, but maybe with the official foreign assistance for family planning, how did that play out in your context? And then we can have any other colleagues with experiences in that regard to continue.
Yeah, I can just maybe add that aspect, because in Burkina Faso, we are trying to work closely with UNFPA Country Office. There's an ongoing project called the Matching Funds Project, which is about, trying to mobilize additional domestic funding to support the purchase of family planning commodities. And that project is supported by the Bill Melinda Gates Foundation. What does it mean? If the government of Burkina Faso is going to invest 100 million CFA for the purchase of family planning commodities, then the matching fund will go to multiply by 2. This means that, if the government is going to provide 100 million CFA for the purchase of family planning commodities for 2021, then the Melinda Gates Foundation will provide 200 million. So it's like a way to incite the government of Burkina Faso and all national private sectors to provide more incentive and more funding to support the purchase of family planning commodities. But we try to also to work very closely with the Family Planning Working Group, which is a coalition of civil society organizations working on SR and family planning. We have built their capacity to develop what we call scorecards. The scorecards, include core family planning program performance indicators and budget indicators. We have developed also what we call a budget tracking tool. The budget tracking tool is used by that civil society coalitions to track, on quarterly basis, the flow of fundings, how the government is using the funds allocated for family planning, for the purchase of family planning commodities. And every quarter, that coalition of civil society organization is calling feedback meetings to provide feedback to the Ministry of Health, of Finance, and Budget to talk about, how the money allocated for family planning has been effectively and efficiently used. And then, both civil society organization and Ministry of Health and Ministry of Finance, they work together and come up with, concrete and practical recommendations, solutions on how to overcome problems about, how to increase the absorption rate of family planning fundings, and how to make sure that, the money allocated for family planning has been used efficiently according to the national priorities.
Okay, thank you. And I mean, that's quite interesting. The budget tracking tool. I'll be quite intrigued to see what that looks like. Penelope, I'm not sure I'm seeing any other hands up. Do you see any?
No,
but I'm tempted to pick on people I know very well within my context and who are on this call. I think I see Achilles, Mr. Achilles Chiwanuka, and I know you are in the advocacy space, so I'm sorry to put you on the spot. Either you or I think Moses dropped off, if I'm not sure. If you can say something about how funding, especially domestic, both domestic and official funding, worked out in your context, that would be really interesting for us to listen to here. Do we have Achilles in the room? So probably is muted, but does anyone else have any contributions in this regard? Penelope, I think we have about 10 minutes to go.
Yeah.
Yeah, so we're still good on time.
Right. Well, I'll just add something that we've seen on the JSI side. We're part of the Reproductive Health Commodities Coalition, and basically people coming together to look at some of the issues. And there have been several meetings of the group that's really looked at what are some of the issues around family planning supplies and commodities, and bringing that data together at a global level, and what are the issues that people are seeing in different countries. Moses, oh, he's off the call. He's with UNFPA. So I don't know if I didn't participate on that group myself, but certainly JSI staff have. And I think looking at that data and having that available both at the country level, as some people have talked about, and at the global level, coming back to the question about how do we influence funders, is having that information available is obviously critical, and partnering with groups to get there in the face of the crisis, but to share those stories, similar to as we're doing here today, this morning, sharing what's worked and what's not worked. Those kind of partnerships are always valuable, I think.
Yeah, and that was at the level of supplies at the global. Did that include looking at in-country data, maybe selected countries?
I don't, in the report that I've seen, it has not dug into those sort of individual country lessons. It's more on the global basis, but I'm sure as part of the discussions, people who were coming from different countries would have provided that input.
Okay, yeah, that's great. So the partnerships both at global country level to avail data, to analyze. And I think someone, I think that was Lamine, I think there was a big, it looks like there was a big focus in Burkina Faso to use data when you learned that initially the government had responded without using evidence, and then you organize the rapid assessments. I really like that, that intervention at that point. Personally, I also have some experiences to share. Of course, I'm in Uganda and Kampala, and I relate very much to what Moses shared in the beginning and how the country adapted. But also at the time of the pandemic, I was working with the Knowledge Success Program, and at that time as a family planning advisor, and we did do with a few colleagues a review of how a few countries in the region were adapting and responding. So and we used a qualitative analysis methodology to look at the guidelines and how they responded. And I found, I think I looked at 6 countries in the region, maybe the East African countries, Uganda, Kenya, Tanzania, and then Zimbabwe, I think, and Zambia, and Tanzania, of course. And it was quite interesting because one of the key things was that in countries, family planning was maybe not immediately, but within a few weeks or a month, it was already prioritized as essential. And many of the things that Moses spoke about, where the countries, the advocates ensured that it was on part of the key agenda of the task force committees for COVID response. But the other interesting bit was that there was disparities in how the different countries responded in terms of what they prioritized for family planning, as the options, especially for the end user, where you found that certain countries felt that some countries were more innovative and very open. So like Kenya was very open. They opened up the private sector, probably the same with Uganda. And then you found that some were a little bit restrictive, and they were asking people to stay more at home, do not go out, but try to use maybe traditional methods, try to use ECPs. And then so countries like Zimbabwe were pushing for that kind of arrangement. So there was differences in how different contexts responded, and that was quite interesting. But what I would like to say, I think as we wrap up, because we have only maybe 5 minutes, unless there's anyone with...
So there's a question from Teresa. From Teresa about what has not worked well during COVID.
Okay, great.
And I think Moses touched on that there was a dip in the first few months. I mean, I know in the first few months, everyone was focused on COVID, and it took some time for people to take a step back from that and then say, all right, these existing health services must continue, as it became clear that this was a longer term health crisis, COVID, than I think many people had anticipated at the beginning. Does anyone have any thoughts on that? And then Adenike also has her hand up, but if people have thoughts on what hasn't worked well and how that was overcome, that would be helpful.
Adenike, do you have something to submit in that regard? You have the floor.
Thank you. I wanted to respond to the funding for FP commodities. Sorry, I was actually trying to look out for a particular data which I couldn't lay my hands on, but very briefly, for example, in Nigeria, UNFPA has been largely responsible, for supporting with FP commodities and all that. But I think what can really work well for us looking forward now is to open up the space for public-private partnership, for governments to look at creating basket funds for family planning, commodity procurement, as a means of domestic resource mobilization. I think that will really, really help in making sure that at least we have all the commodities available 24/7 across our facilities to save our women and girls.
Okay, yeah, thank you.
And Sam's hand is also up.
Okay, Sam. Yes, Sam, go
Yeah.
ahead.
So one of the things, reflecting back during COVID time, we have countries that did a commendable job in terms of coming up with national guidelines on continuity of health services, within a very short time. But because everybody didn't know how this pandemic will behave, some of these guidelines were extremely restrictive, cutting out also a number of services. For example, some of the guidelines, like in Kenya, family planning was restricted more to pills, for example. Some of these lax and voluntary surgical contraception, they were seen as a no-no during that time. So the guidelines will ask even women stocking some of these pills in advance. So what did that make? When you now look, you reflect on the data around some of these methods, then one notices that perhaps maybe at that time, it would have been even okay to encourage some long-term methods because they will not need to be visiting the facility frequently, and all that. So the restrictions, and it's understandable because nobody knew these things. You'd rather be abnormal in your restrictions than normalize a bit better. But reflecting back, you could see that looking at the data, some of those restrictions would have been more from, instead of a blanket restriction, but on a scenario-based restriction, so that one can say, if your health facility is in a context where we are having scenario A, then these are the kinds of services you can provide. If you are in those that are in scenario B, this is what you can provide in terms of services, as opposed to a guideline that tells the whole country to be at standstill, because some areas in the country had not even received most of these cases. They had 0 cases, but they are to obey the same restrictions. So these are some things that, reflecting back, one could see that it could have been done better in terms of that. But then it is understandable, given that we are all learning at that time, Even the Ministry of Health was also learning and all that. So it was, and we are still, I think we are not out of the woods. There's still more learning that we can still do around the COVID issue.
Well, Sam, you just really nailed it. So blanket restrictions, not scenario-based, maybe not even evidence-based. But anyway, we were responding to an emergency. So maybe for the future learning, how do you deal with such? I think would be the question. So, and that takes us to the closing, I think, Penelope. Yeah, which is what next for planning advocacy once COVID-19 has passed. Of course, we don't know yet when that will cross that line, but yeah. Any good ideas?
And I will just say it is 11 o'clock. So if people need to go, obviously, feel free. I don't know if they're going to shut the room down at some point, but someone else did have their hand up, but maybe they have gone. I think Lemon did. Adenike, lack of data made it difficult. So Adenike is saying lack of data made it difficult to forecast appropriately during the lockdowns. That is very true.
Yeah. And so since it's at the hour, Penelope, I think we shall close this session. And I would like to thank everyone on this group that participated on the group. We've garnered really interesting experiences and ideas of what worked for family planning advocacy during COVID-19. We've learned from many of you about the dips that happened at the beginning and then the interventions that helped get the numbers back. Working with the media, working with leadership and government to lobby for budgets and how governments and leadership responded by, readjusting their budgets and priorities. And also what didn't work subsequently with, especially with Sam's last submission about how blanket restrictions sometimes use lack of use or lack of data affected the decisions that were eventually made, and maybe things would have been different. And this, I think, gives us a bit of takeaways of what to think about in case we have similar emergencies in the future, but also looking forward beyond COVID. I think we've also learned that there were some innovations that might outlast COVID, both for advocacy and service delivery. Thank you so much, everyone. And I wish you the best with the rest of the ICFP Not Without FP forum. Penelope, do you have any closing announcements?
So Teresa posted one thing in the chat that she recommends integration moving forward. She recommends integration with health emergencies to prevent this happening with another pandemic. Yes, agree completely, absolutely. And Catherine's giving you a thumbs up too, excellent. Any other final thoughts as we're clearly not being kicked out yet? This is recorded. I think they will be posting the recordings. And I know Frederick has been asked to, he's a rapporteur, so will be, those points will also be put out publicly for people. But if people did take notes and want to share those, happy to have them. My email is p.riseborough, you see my name on the screen, @jsi.com. And Frederick, I just want to thank you very much for your masterful facilitation, which is never easy on Zoom. It's been almost a year. I know we're all getting zoomed out, but anyway, you did an excellent job. Thank you, everybody.
Thank you to Penelope for the support.
Pleasure.
Yes.
All right, I'm going to stop
Thank you,
recording.
everyone.